Good evening, everyone, and welcome to our Eating Disorder Hope webinar. We're so glad that you could join us tonight. My name is Crystal Cargis, and today our presentation will be on eating disorders and substance abuse, co-occurring issues. And we're delighted to have as our presenter and special guest, Sharon Zimler, a marriage and family therapist and executive director at Montecatini Eating Disorder Treatment Facility. And just as a reminder to all our attendees participating today, you can submit questions to our presenter at any time during the presentation by typing in your question into the text box of your control panel. We will be addressing your questions throughout our webinar session today. And without further ado, I'll be transitioning this over to Sharon Zimler, and we hope you enjoy. Thank you.
Okay, thank you. So am I coming across okay? You guys can hear me? Crystal?
Yes, you sound good, Sharon.
Now, just to make sure, I want to make sure that you guys see my PowerPoint and you don't see this. So maybe, hopefully that'll work. So, all right, well, let me know if there's anything else going forward. Well, thank you so much for having me, Crystal. Really appreciate it. This is a really important topic, something we see so much of in eating disorder treatment, is the co-occurring disorders, specifically between substance use and eating disorders. And we have really taken this on as an important approach in our treatment, because we've had so many patients in the past that have come in who had serious substance use issues, and when not addressing them, just really seemed to not get better, keep going back and forth. So let me start off. So, as we all know, eating disorders have serious health problems and serious health consequence, and they can even be more so when substances are involved with the disorder. And the two of them together create just a lot of complications for assessment and treating and the recovery too. And to give you a little bit of background on why this is such a big issue for me is because I'm the executive director here at Montecatini. I'm a therapist as well, a marriage and family therapist, but I also am in my own recovery from both of these disorders. And there was a lot of problems even when I was going through my own journey, and seeing that if I wasn't dealing with both of these things at one time concurrently, I was likely going to spend months, years going back and forth between disorders, which is what I started seeing when I started doing my doing therapy here at Montecatini. And one of the reasons why my colleague Nancy Stacer, who is our clinical director, and I developed this program specifically to treat these patients, because we didn't want to see patients continue to bounce back between different types of treatment, eating disorder, substance use, and vice versa. So just a little bit over to kind of review some of the statistics. The statistics are pretty staggering, and 8 million Americans have an eating disorder. 7 are women, 1 million are men, and that's probably even underreported. We know that, especially with men, a lot of men don't report eating disorder, and oftentimes a lot of people who have an eating disorder go underreported as well. And I think the important thing to notice, though, is that when you have an eating disorder, you're 5 times more likely to abuse alcohol or drugs. And then that's also the same for individuals who abuse alcohol or drugs. They're even that much more likely to have an eating disorder. And what I tell the patients that we work with here is that just because you've never had a substance use issue, just because you've only had an eating disorder, a lot of our patients say, well, I don't have any problems with that. I just have an eating disorder. And yes, that's true for a lot of people, that they never develop another type of disorder, specifically a substance use disorder. But simply by having an eating disorder, it really sets you up to potentially have some type of substance use issue down the line. And unfortunately, I've seen that happen with a lot of people who had never had an issue in the past, but when the eating disorder was taken away and there was nothing left in the person's mind, they felt as though they needed something, and unfortunately, they turned to other types of maladaptive coping skills. So eating disorder statistics, just a little bit more on that. As most of you probably know, eating disorders have the highest mortality rate out of any mental illness. And there's a variety of reasons why that's the case. I think one of which, importantly, is that the medical issues associated with eating disorders are often so severe, and there's a lot of people that end up, unfortunately, dying who don't get diagnosed or are not told, the families aren't told, well, this was because of your child's eating disorder or a loved one's eating disorder. A lot of times, if it was a heart situation, the cause of death is considered heart failure. But oftentimes, the eating disorder piece of it doesn't get mentioned. So we know that there are likely even more deaths than actually get reported for eating disorders. The National Association of Anorexia Nervosa and Associated Disorders says that 5 to 10% of anorexics die within 10 years after the onset, and that alone is a big percentage. But if you take into consideration that there's a lot of people that may end up dying from, say, for instance, dehydration or heart failure, who do have an eating disorder, that number is also low. We know that percentage is probably even much higher. And unfortunately, the last statistic, I think, is what is really concerning, is that 18 to 20% of anorexics will be dead after 20 years, and only 30 to 40% ever fully recover. And, the reason why I show these statistics and I talk about these statistics are, first of all, it's important to understand what we're dealing with, what the reality is of an eating disorder. But then to know how serious this is also warrants taking serious steps towards recovery. I wonder if that 30 to 40% that will ever fully recover is 30 to 40% because maybe some of the co-occurring disorders that the person may have do not get addressed during this process. So another reason why it's so important to really look at both of these disorders. A little bit more here with some statistics, but so 20% of people suffering from anorexia, of course, this is going back to what we said, prematurely die from medical complications, but suicide is also another big factor. And it's really scary when you think that eating disorders are the main cause of death for females from 15 to 24 years old. That's a pretty staggering number. And I think that really highlights how serious the disorder is. And like I said, if you then factor in another disorder such as substance use, these statistics become even higher. So why are these important? Well, it's important to understand the seriousness of having more than one disorder and understanding how one can affect the other. And also, too, realizing that substance abuse, not just illegal drugs, but over-the-counter drugs and alcohol are a really common disorder that occur with eating disorders. And a lot of times what happens is patients with eating disorders sometimes start their journey into substance use by finding things to affect their weight or to aid in their disorder. So for instance, sometimes that starts with laxatives or diet pills or diuretics. And I see a lot of people that say, well, I don't have a problem with drugs, but I do abuse laxatives, and I do abuse diuretics, and I do use diet pills because it's all about my weight. And for some people, that's where it ends. But for some others, that just is the beginning and opening the door to a whole different world of a substance use disorder. Because there's so much that goes into the mind and the ritual of all of that with someone with these two co-occurring disorders. I've worked with several patients in the past that just the ritual of it, you know, doing something like taking the medication, buying the pills, all of that becomes such a big part of this process. And so when that eating disorder component is taken away, it's that feeling of, if something doesn't feel good within me, inside of me, if I take some sort of medication, I will feel better. So I hope that makes sense. But sometimes, like I said, this really is the beginning into the substance use disorder, by just trying to find things to affect weight and appetite. So here are some substance use statistics. And once again, just to kind of put some context into why this these co-occurring disorders are so serious, because in and of itself, substance abuse statistics are pretty staggering. This was from 2009. This is an older study, but 23.5 million people, that's a lot of people, needed treatment. And very few, actually, let's see, 2.6 million actually ended up getting treatment at a specialty facility. So you think about the other 21 plus million people out there who never were able to receive treatment, at least in a treatment facility, and what happened to them, where they are. Did they get clean and sober? Are they still struggling? An estimated 8.9% of the population, which is about 22.5 million people, age 12 or older, are classified with substance abuse or substance dependence. And this is based on DSM-4, not DSM-5. But that's 8.9% of the population. It's funny because I've been hearing a lot, even in recent news, actually a lot even to do with the presidential candidates coming up. But drug addiction has become a major hot topic in the news with our presidential candidates even now. And I heard a statistic this morning saying that there was a poll taken that more people were concerned about drug addiction than they were about the economy and something else. That's pretty amazing. That was the first time I had heard that today. But it's really on people's radar right now. It's on the government's radar. It's on the American people's radar. And if you think of this, looking at these statistics, how many of these people are suffering, and how this then inadvertently affects all these other areas, family, economy, jobs. It's so far-reaching. So the co-occurring. So these are the statistics which I really think have a pretty big impact on the professionals that I talk to, because I think that sometimes people don't really realize how much these two disorders occur. So 50% of people with an eating disorder abuse drugs or alcohol, compared to 9% of the population. That's a pretty important number right there. So 50%. And I often say too, I wonder, if that statistic could be even higher. When the patients that we have here at Montecatini, there's times where 70, 75% of our population has some sort of co-occurring substance use disorder. So we see it quite a lot. There's a lot of people too with eating disorders that really minimize or try to are in a lot of denial about any type of substance use disorder. We see that so often when people are looking to even come in for treatment. We ask them some pretty extensive questions about their substance use history, and oftentimes it's a lot of downplaying, like, well, I have some wine, or I drink a little bit here and there, or I have a medical marijuana card, and there's a lot of minimizing on that side of it. And then after further exploration, we find out that there's really sometimes some serious substance use disorders that the individual hasn't disclosed or wasn't wanting to and willing to disclose. So the next statistic, 12 to 18% of anorexics abuse or are dependent on alcohol and drugs. Now, in a lot of statistics and a lot of what we hear is that anorexics don't often have as much of the propensity to be dependent on alcohol and drugs, but that's a pretty It's a pretty big statistic alone, 12 to 18%. Usually the remaining are bulimics or binge eating disorder, but I also think too that that number could even be a little bit higher. And then one study also found that women with either a substance use disorder or an eating disorder are 4 times more likely to develop the other, which is what I was saying before, that it's so important that we explain and educate our patients that just by them simply having an eating disorder sets them up to even be more inclined to develop a substance use disorder. And the last statistic that another study reported that 14% of women with a substance use disorder had anorexia and 14% had bulimia nervosa. I think the most important thing to take away from all this is that there has been research that has been done, more studies are being done on this, and different information is coming across all the time. I know that, like I said, just from my own clinical experience, by what I see, the women that we work with here, the numbers are pretty high. And what it does to the person, to the individual, is really hard, and it makes this whole process so much harder of recovery if they can't deal with their substance use issue at the same time. Okay, so what's the problem? The problem, our researchers found that women with either a substance use disorder or an eating disorder were more than 4 times as likely to develop the other disorder, which is something we've been talking about. But what's interesting is the eating disorders became more severe, the number of different substances used increased. So we see changes within the patterns that the patients have with their substance use. And I know with the people that we work with, we've had a lot of people come in who never really seem to have much of a problem with, say, for instance, let me see, maybe alcohol. Maybe they were just doing opiates, or maybe they just were doing certain medications to help them lose weight. But inevitably, the option of using different things, of basically getting out of yourself, having something to cope with the emotions. Hello?
We can hear you now. Thank you.
Okay, good. Sorry. How long was I?
Oh, it was just about 30 seconds.
Okay. Okay, good. Well, good. Sorry about that. So kind of going back to, I guess, the way in which people with eating disorders use substances in order to enhance their eating disorders. So a lot of people use, of course, substances to lose weight, whether it's by purging, using diet pills, stimulants, amphetamines. A lot of people start by maybe trying some diet pills and then see that, well, maybe if I used cocaine, or maybe if I used meth, maybe I would have a better result. We have a lot of people who abuse medications for ADHD, stimulants such as Ritalin, Adderall, Vyvanse, and use those types of things to see how much weight they can lose. And oftentimes it starts by first trying out some over-the-counter type of diet pill, sometimes even some of the natural types of weight loss things. But it's really just the mentality of when I'm willing to or wanting to lose weight so badly that I will use some sort of substance, people become desperate and they start trying anything. And actually, it's funny, we see a lot too with sleeping pills. A lot of patients abuse their sleeping pills, not only just to check out and not feel, but a lot of times the hope of maybe if I can just sleep, then I will not be eating. And then with heroin, heroin is also used to lose weight. It seems logical that, a lot of the stimulant type of things like cocaine and Ritalin, Adderall, that type of thing would be common. And a lot of people are surprised when they hear that heroin and other types of opiates are used to lose weight too. And the reason is heroin and other types of opiates, painkillers, over the counter, not over the counter, I'm sorry, but prescription pain meds really do reduce appetite for a lot of people. And it makes it a lot easier for somebody to lose weight when they have no hunger cues. And in addition to the street drugs and the more obvious drugs, caffeine is a big thing, and tobacco, of course, but we see a lot of patients who start out by drinking a lot of coffee, then maybe taking a lot of energy drinks, that type of thing. But unfortunately, people end up going even further and start buying caffeine pills. They start getting that, they try to really affect their metabolism with caffeine. And then a lot of times that leads to more intense things like cocaine, meth, that type of thing. So it's interesting to see how the over-the-counter medications often lead to more illicit drug use. So there have been some studies that have shown there are certain correlations between alcohol, drugs, and the eating disorders. And so alcohol abuses and drug use are common with bulimics. And bulimic women overall report higher rates of suicide, anxiety disorders, personality disorders, and other substance dependence disorders than women who are not alcohol dependent. And severe binge eating disorder was also consistently associated with alcohol use. So there have been quite a few studies on these things to see what it is. Is it something in the brain? Is it something personality-wise or personality structure that makes a person with an eating disorder more likely to be an alcoholic or abuse drugs? And they are finding through a lot of research that there are commonalities. I think one of the things is when you really look at personality structure and you start thinking about, say, for instance, bulimia, there's a lot of impulsivity. And so you take the impulsivity that you see with somebody with bulimia, and that's often very common too, of course, with certain drug use and alcohol abuse. So there's a lot of crossover just with the personality types. For instance, like with anorexia, we see a lot of our anorexic patients, not only just, but in bulimia too, that are very perfectionistic, that have such strong and rigid beliefs and expectations of themselves. And then we also see those people not wanting to lose so much control with drugs, so they take different drugs or drink alcohol just to the point where they don't lose control, but they have some sort of relief. So there's interesting correlations between the eating disorders and the types of substances they use. So we know that this happens for a lot of reasons, and people with eating disorders and substance use disorders, these are ways to not deal with emotions. It's so hard for people oftentimes just to be in their own skin, and they need something to just go through the day, deal with them, just deal with these things day in and day out. But what happens is we see a lot of patients that are in recovery from an eating disorder, they even go to substances to use for aid in the stress of recovery. Because all of a sudden it's like the whack-a-mole game. You know, you hit one and then something else comes up, and then you hit that one and then something else comes up. So a lot of people just kind of flip-flop back in order. And, you know, they use one disorder to compensate for the other. So when you take one away, there's a real hole that people feel and a void and a lot of fear of how am I going to get through this without ever using something to deal with the stress in my life. And that's when the other disorder tends to become more prominent. So we see a lot of flip-flopping back and forth, which is why concurrent treatment is so important. So a lot of people ask, well, is it important, and why, what if, which one came first, and does it really matter? The reality is it probably doesn't necessarily matter so much, because what matters is how is it presenting right now? What's going on, and which one is, you know, some people say, well, the one that's primary is the one that should be treated first. And there are cases where in certain situations, if drug addiction is primary in the assessment, or if eating disorder is primary, that there are certain things that need to be stabilized first before going on with treatment. But what we see here in Monocattini is that it's hard to really make any headway with either unless both are being addressed or are at least somewhere on the treatment plan going forward. So there's been some different ideas and different explanations why these things co-occur. Here's just some of the ideas. Some people think that maybe they have different causes, but the presence of one increases the chance of developing the other. I think there's some likelihood to that. Another idea is maybe one independent disorder caused both disorders, so something completely separate causing both disorders. And you know, there is a lot to say. You know, people who have had depression or trauma or anxiety, sometimes those things occur first, and then the development of an eating disorder or substance use comes later. Sometimes the two disorders, you know, they share a lot of the risk factors. They have the same things in common, and some, like I was saying earlier, are more specific to each disorder. And we always do look at some sort of what's underneath it. What's the underlying etiology? What's driving these two disorders? And usually, this third proposition here, it is some sort of thing that is driving both disorders. So we really have to get to that part of it in treatment so we can really effectively treat the stuff that's driving the behaviors. And then the last one, this one's been studied the most, says that there's a predisposition towards impulsivity, and that relates to a common mechanism involving an endogenous opioid. Now this is interesting because an internal opioid compound that naturally occurs in the body acts like an opiate and has been shown to play a role in regulating alcohol consumption as well as appetite. So essentially what this is saying is that there is a biological component, something that happens to people's bodies internally, that then ends up playing a role in regulating how people metabolize, how people feel when they drink, when they eat. And that's a really interesting one. There is a lot of research that has been done showing, and some really important findings that have come out, that there are people that simply have, no matter what, even patients who don't have eating disorders, have a difficult time knowing their own hunger and satiety. We've seen reports come out where there are people that don't often have the ability to feel full. There's a lot of things that do occur biologically in the brain, neurochemistry, that affects that type of thing. And two, even with addiction and the research that's done in that field, the metabolism and the way that addicts and alcoholics metabolize alcohol and drugs is often very different than the way somebody who is not an addict or alcoholic metabolizes things. So I think that what's important to note is that there's a lot of different things that need to be considered when treating both of these disorders. Going back to some of these other commonalities, so, the coping mechanism and looking to find something to replace when the feelings and what comes up when one disorder is taken away. When we are treating these types of patients, we have a particular program that we've developed that I mentioned earlier to deal with both of these things. And the goal of this is to really kind of pull aside, whatever the disorder is, but to really look at the underlying stuff, to look at how to find newer, healthier coping mechanisms and all of those things, but also really looking at what can we do to help somebody feel like they have something else that they can use to get through the day besides one or the other disorder. And also, it's interesting because a lot of times there's such a huge fear too, of course, of weight gain and what a lot of people rely so heavily on the substances to keep weight down and to lose weight, and it's just those two things can be so strongly intertwined that makes it's difficult to treat. So when we have seen people, we've seen other disorders, that depression, obsessive compulsive disorder, anxiety disorder, that types of things, that we also see have stronger correlations with eating disorders and substance use. So one of those things is that substance use disorders are often more likely to suffer from OCD, panic disorder, social phobia, and individuals who have substance use issues that precede their eating disorder are typically more dependent on substances and have developed their dependency at an earlier age. And when we look at treatment, when we look at what is the best practice for treatment of patients with co-occurring disorders, we have to be able to assess, of course, the need for psychiatric medications. And what we find is that because of these things like OCD, panic disorder, social phobia, depression, anxiety, and those things driving sometimes the use of substances and eating disorder behavior so strongly, those things have to be very strongly addressed in the treatment process. And there are a lot of medications, psychiatric medications, antidepressants, antipsychotics, that have shown to be incredible in helping promote the recovery process for a variety of reasons. But what personally, something that I've seen a lot of is, there's such a common thread between our patients who have this, that there's always their mind just going all the time and constantly thinking, you can't stop obsessing about, what I'm going to eat, my weight, food, how I'm going to get rid of the food, how I'm going to get rid of the calories, or how I'm going to get my hands on the drugs or alcohol that I need. But the fact that the brain goes so quickly and the mind is really spinning quite a bit is something that makes it very hard for patients to really focus on the recovery, or to even let other ideas, messages, and things in. And in these situations, different types of medical and medication interventions can be really effective. So kind of just a little bit more about the whole brain here is that, we've seen that the pleasure center of the brain that is so much triggered by substance use, and also, of course, very much triggered in eating disorder behaviors, that is a really tough thing for some of our patients to be able to overcome. So this one point says that overeating may result when stimulation to the brain's pleasure center is lessened during withdrawal from substances. So the pleasure center plays a really big part in both of these disorders. Sometimes the pleasure center is just, like it's saying here, is really just dulled out, and it's hard to even notice hunger and satiety, or it's taking more to feel pleasure and to have that surge of dopamine, or there's also a lot of studies showing the deficiency of serotonin and other types of neurochemicals. So a big part of how to recover from these two disorders really does have to be focused on the biological and neurological aspect of it. Other things to really consider, though: genetics, cultural influences, environment, social factors, trauma, and the brain and attachment. These are really important to assess and to focus on too, because both of these disorders are incredibly complex, and there's a lot of different facets that need to be addressed. And for each individual, some things may be stronger than others. So for some, the environmental factors may be more prominent. For some people, it's the trauma. We work a lot with patients who have severe trauma, and the substances and the eating disorder are their way of not feeling that trauma. So it's important to see that each individual may have stronger issues in one side, whether it's cultural, environmental, or social. So some of the just overview of the shared risk factors. There's the common brain chemistry, and a lot of times these things occur when there are times of transition or stress. Usually both of this patient with both of these disorders have low self-esteem, depression, anxiety, and impulsivity. Oftentimes history of physical, sexual abuse. There's sometimes, there's a family connection. There is unhealthy parental behaviors or low monitoring that some children just don't have much oversight when they're growing up and start finding these maladaptive behaviors early on. Social and peer norms, but also too we can't forget that advertising and social media, entertainment media, has a huge impact on the developing brain. Some other shared characteristics: so the obsessive preoccupation, craving, compulsive behavior, secretiveness and rituals, the experience of mood-altering effects, isolation, the link to other types of psychiatric disorders and suicide, the fact that they're both difficult to treat and can be life-threatening, and they both require intensive therapy and have high relapse rates. But the secretiveness and ritual part of this is important, whether you're looking at co-occurring disorders or if you're looking at eating disorders alone. But the ritual part, the secretiveness part, is something that becomes somewhat of a high on its own for some of our patients, and not being able to have that little secret or that ritual is just as hard to consider overcoming, sometimes even as much as the eating disorder behaviors, and that's the same with drug addiction and alcohol use. What makes this really hard is that you can go through life, you can go through the rest of your life and never have to use a substance or alcohol again. But for a patient with eating disorders, that's not the case. You really have to learn how to find a relationship, form a new relationship with food, and be able to find a healthy relationship with food. And when you have to eat on a daily basis, every time you're sitting down at a meal, that experience is tested. That anxiety comes back up. Those feelings come back up. So you can't really just turn your head and walk away from it. It's this constant reminder of, wow, how am I going to deal with this? And the stress of that can sometimes be just too much to bear. Like I was saying before, it's easy to sever the relationship. You can sever the relationship with alcohol and substances completely, but it's not possible with food. And in order to recover from both of these things, of course, they both need to be treated concurrently, but at the same time, the eating disorder has to be evaluated oftentimes in a different way. So for instance, it's clear what happens, what a relapse is with substance use and alcohol and drugs. And simply if you drink or use, that's considered a relapse. But a lot of people wonder, well, how am I supposed to gauge what a lapse or a relapse is with my eating disorder? And it's hard for people to really kind of even understand where they are in their own recovery process, because it's not necessarily something you can say, if you have one episode of restricting, if you have one episode of purging or binging, then you have completely relapsed. But what happens is for the individual who's doing this, who's going through this process, it's important for them to really have a clear understanding of what that means and what that looks like for themselves. Because if the person feels even that much more defeated, like I'm never going to be able to do this, this is too hard, I can't stop both, I can't lose both of these things, a lot of people just end up giving up. So kind of evaluating it from a treatment standpoint of, for that person, what is it going to look like to lapse or relapse in your eating disorder, so people have a clear understanding of where they need to be in order to start making strides in recovery. So just a little bit, so we know, these things are not well understood even by people that are supposed to be professionals. A lot of medical doctors don't really know and understand the connection. And unfortunately, people get a lot of maybe not the best direction on how to deal with these things, because this is a complicated situation, and a lot of treatment centers don't know how to treat these things effectively. And unfortunately, I see people come in quite a bit who just feel really defeated and feel like I'm never going to be able to recover. It's too much to try to get rid of both of these things. So I think in going forward and looking at the right treatment options, when we can give and present options to people that are going to work on treating these things concurrently, they're going to feel more hopeful. They're going to realize, wait a minute, I can do this. There is a chance that I can truly recover from both of these issues. So our goal here is really just to provide scientifically driven, evidence-based treatment that treats the whole person, but addresses the co-occurrence of the eating and substance use disorder in an integrated approach. And so the integrated approach involves a lot of these things. It involves CBT, DBT, family therapy, motivational interviewing, some 12-step facilitation in substance use education, and pharmacology. We've created this really great program that helps us integrate all of these things together. And in doing this, this has given our patients an opportunity to deal with, like I was saying earlier, the underlying causes, the stuff that's really driving the behavior, and to be able to look at their treatment from all these different modalities. So it's not limited just to eating disorder treatment. This is a bit of an overview of what our facilitation model looks like. And to just kind of sum it up quickly, it's really adapted on 12 steps, but it's not the 12 steps. What we did is we really pulled out the principles behind the 12 steps and have found a way to use and build a whole program on the principles by going through a very structured weekly and bi-weekly group that we have at our facility. We go through some of these principles of the 12 steps: acceptance, surrender, action, and have specific assignments that we give to patients, homework they have to do, readings that they have to complete. They also are encouraged to go to 12-step. We bring people to 12-step meetings, and for some that don't want to go to 12-step and want to go to some other type of support group, we just want people to find outside support. We help facilitate that. And it's always so important just to remember that there is hope and that people do recover from both of these disorders. And fortunately, I'm in a place where I get to see it all the time. I have seen some pretty incredible cases, and people come through here that really felt that they were never going to make it. People that were so strung out on heroin, so badly in their eating disorder, horrible trauma, who have been able to reclaim their lives. So anyway, that is, there are some things here too, just to take away, that once again, if these are treated at the same time, you're better off. And always find people and professionals that do understand these two disorders, so you don't go back and forth. You don't end up playing that whack-a-mole game, because that can get pretty exhausting. And it's important to really look into the people that you're working with on a clinical basis to make sure that they have a good understanding of different treatment options for people that have these two disorders. And And I think with that, that is the end of my presentation. We'll just stop with this image.
Thank you so much, Sharon. That was a wonderful presentation, and we just appreciate you sharing your expertise. We do have a couple questions submitted from the audience. The first one is, for treatment centers that primarily address and treat eating disorders, what recommendations would you make for professionals who are screening or assessing clients for co-occurring disorders?
Well, if there is a treatment center, a lot of treatment centers don't want to treat individuals with strong co-occurring disorders, but for those, I think it is important to do a thorough assessment. And if I'm not answering this all correctly, please let me know what I'm missing. But what is important is to be able to actually assess comprehensively for both, because a lot of treatment centers just have a little bit sometimes of the substance use piece of it. Sometimes it's only related to eating disorder types of things. But even if you're not a treatment center or a treatment center or a professional that does treat both, overall, you really have to know, in order how to develop a good treatment plan, what you're dealing with that person. So I think just having a comprehensive assessment on all sides is first and foremost very important. And I'm not sure, is there anything else with that question, Crystal, that I didn't answer?
I think your answer was great. Thank you. We weren't getting any more questions about that. We had another question just about general outcomes for individuals who are struggling with co-occurring disorders, and do you get treatment for both? What is usually their prognosis going forward, and do you have an idea of relapse rates or anything like that?
I don't have, we do a lot of our own data collection. I don't have statistics on relapse rates, but what I do know is the relapse is going to be contingent on the type of treatment. And so the key is not treating patients like this sequentially, meaning not doing drug abuse treatment and then doing eating disorder treatment and then, that type of thing. And this is research-based now too, showing that the best likelihood for full recovery is by treating concurrently, so treating both of the disorders at the same time. With that, when you treat in that way, the likelihood of recovery is that much better. Unfortunately, I don't have the statistics, but I will say from my own clinical experience by working with so many of those patients here, we have a lot of patients. I'd say we have a pretty good percentage, maybe 30, sometimes even 30 to 40%, that those of which who are completely open and honest about their substance use disorders and eating disorders, that end up recovering and staying in recovery. We have a great alumni base at Monocattini, so we have so many great, our patients stay very close to us. We want them to stay close to us, so we get to see, and we see a lot of our patients recovering completely from both disorders. So
that's really great to hear. Thanks for sharing that, Sharon. And also another question just regarding priority of care. So for example, if you have a patient that comes in with the need to detox from a substance and they're also dealing with a co-occurring eating disorder, how is that typically addressed?
Yeah, that's a really good question, and that was a really important thing for me when in developing this program, because I wanted to be able to have the capacity to detox people. Of course, we have 24-hour nursing. We have a great doctor who really specializes in this, and great nursing, great medical staff. So I want to be able to, if possible, and we've done this successfully, detox the person here in eating disorder treatment, because if we do that, then immediately we can start the feeding, the hydration. We can watch that part of it. So often, a lot of patients with substance use that need to detox, and they also have an eating disorder, they go to substance use facilities, and they detox, and they know that they're going to be able to restrict, or they know they'll be able to over-exercise or binge or purge, and they don't have to really start working on their eating disorder. But that's dangerous because if we're not looking at hydration and nutrition while a patient is detoxing, it's going to set the person back. And we are able to do that all here. But there are times, of course, where medically, if somebody needs inpatient hospitalization to detox off of the drugs and alcohol, they do that. Sometimes it may take several days or even a week. But then as soon as possible, they come in and start looking at the eating disorder and substance use, because unfortunately it's just going to delay any type of recovery longer if they're not if they're acting out in any type of eating disorder behavior.
Really great information. Thank you. And just in closing, as a last question, can you share just a little bit about Montecatini and maybe where someone can find out more information about this treatment center?
Sure. Montecatini is we're a treatment program. We have 3 levels of care: residential, PHP, which is 8 hours a day, and IOP, which is 4 hours a day. We're located in North County, San Diego, California. We have 2 beautiful residences for residential treatment. We really try to offer individualized home-like environments, only 6 patients per house, so patients get a lot of intimate individual treatment in a really beautiful home setting. We're very close to the beach. We spend a lot of time outdoors, really using our environment in order to help treat patients. And our outpatient PHP and IOP program is about 10 minutes away from our residential homes. So any interest in contacting us, you can contact our admissions department, and that's area code 760-436-2657. And we have somebody 24 hours a day who is available to take calls. You can leave messages as well if somebody doesn't get back to you right away. But we have a national call center also that can take calls. And our website is www.montecatini-eatingdisorder.com, and you can get a lot more information there, and also find different resources, find different information on eating disorders in general, and just get more program description from our website.
Wonderful. Thank you so much, Sharon, and thank you again for being here with us tonight and just sharing your amazing expertise on this topic. And thank you again to everyone for attending our webinar on eating disorders and substance abuse, co-occurring issues. If you have any other questions, please feel free to contact us directly at info@eatingdisorderhope.com. Once you leave today's webinar, you will receive a survey on the presentation. We would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to review a recording of today's webinar. On behalf of Eating Disorder Hope and our presenter, thank you again for joining us today, and enjoy the rest of your evening.
Thank you.